Hello and welcome to Creating Hope in Our Community, our 5-part series of podcasts focusing on all things suicide prevention. I'm joined in the studio today with Jenny Hutton. Jenny, how are you doing today?
I'm doing fine, thank you for inviting me along.
Not at all, always a pleasure to see you. Can you tell us a wee bit about what you do, your role with NHS South Lanarkshire and how it pertains to suicide prevention, please?
Yeah, of course, Matt. Hello everybody, my name's Jenny Hutton. And whilst I'm trained as a psychologist and I've been working in Lanarkshire since 2008, which feels like such a long time ago, I've got a public mental health role now, and I've got the lead around what we call Good Mental Health for All, which is the sort of public health component of our mental health strategy, which is really about how we work together to create the conditions for everyone to thrive, whether that's empowering communities to help each other, supporting our fantastic voluntary sector, whether it's tackling poverty, working with colleagues in housing, education, social work, green space regeneration, working with some of our most vulnerable residents just to ensure that promoting good mental health for everybody is right down the middle of everything that we do and that we're supporting everybody to thrive.
Great. Okay. Now, this series of podcasts, like I say, is about suicide prevention. Can you tell us a bit about how would you define suicide prevention, Jenny?
Oh gosh. Okay. So I think about suicide prevention in 3 parts. The first part of that is that I think there's a really important bit about timely access to support at a really early stage. So suicide doesn't tend to come from nowhere. Often there's things that happen to people, or whether that's financial struggles or bereavement or a physical health diagnosis, loss of a job or any kind of multitude of life events that befall folk. We need to challenge the stigma of mental health and get people talking about it and prioritising support for people in workplaces, in communities and schools, for families, and recognise that value early on in helping each other and compassionate conversations and just listening and recognising that suicide doesn't come from nowhere, but it can just be the smallest thing that breaks the camel's back. That one stress and one stress doesn't make 2 stresses. It's that kind of cumulative, and it can be something really small, but it's really important that we get in early on and create the conditions for everyone to thrive. So that's the first bit. That's the really kind of upstream bit around suicide prevention. Secondly, there's what we do when people do present in distress and when people's pain has become so intolerable that seems like the rational thing to do. Lots of us contemplate suicide at some point in our lives. Of the hundreds of people that I've spoken to over the years, I think probably most of those people that I've spoken to have said, yes, they've thought about suicide at some point in their life. Some of us then go on to think about, actually, how would we do that? What would our plan be? And then people have varying levels of whether they've got the intent to carry out that plan. So when we're speaking to people, you're exploring that in terms of, so lots of us think about it. A smaller proportion have a plan, a smaller yet proportion think about, right, actually, I'm not going to be here tomorrow because I've got that level of intent. And how we respond to that is with compassion, but also with a degree of getting people to the right place, depending on where they are in that journey. For example, in Lanarkshire, when COVID came along, there was a huge transformation of services, and we now have an out of hours psychiatric liaison team. So previously, when people were at that, this person's really not safe, I'm worried that they're not going to be here tomorrow. The only option was police would take people to A&E and sit with them for 8 hours in a very busy A&E department. Now we've got a psychiatric liaison team that will link with the police, that provides very quick access to clinical expertise, will assess people, will bring people in if that's needed, will go out and see people at home if that's needed. And that frees up police time, but it also means that you're giving people the right support at the right time. One of the other newer initiatives, I'll say new, it's been around for a few years now, but we've got something called it's Distress Brief Intervention. It's Scotland-wide, but it was born in Lanarkshire, which is a collaboration between the voluntary sector and health and social care. GPs, emergency services, A&Es can refer people in distress for crisis support, and that person can access skilled crisis support within 24 hours. Somebody will contact that person. So it's not, 6 months on a waiting list. It's not, that person needs support now. So those are some of the transformations that we've put into place. And thirdly, something that we don't often talk about in terms of suicide prevention is what we do after somebody has attempted suicide. That I think if somebody's attempted suicide, statistically, they are more likely to go on and complete. It's a barrier that people have got over. So I think how we treat people who have either self-harmed or attempted suicide, and how we provide that support to get people back on track again. Sadly, when people do take their lives, we know that has a huge impact on families, on colleagues, on communities. And unfortunately, when we have one suicide, again, statistically, the risk of somebody else completing suicide, being impacted by that. So there's a huge amount that we have to do to try and support communities, support workplaces, support schools around about attempts and completed suicides. So 3 parts to it, I think. Prevention, the very early intervention, crisis response, and then what we call post-vention. What do we do in the event of somebody having taken action?
I was speaking to, excuse me, Donna from Neil's Hugs. I don't know if you've met Donna.
Yes.
And she mentioned something like, and it's just kind of what you touched on there. She said, I can't remember the exact number. I think it's something like, for every one person that completes suicide, there's, is it 37? That's the number I've got in my head. It could be more, it could be less. People around them are affected.
Yes.
And therefore it potentially at risk themselves.
Yes. And I think that's old money. I think that's in the old days before we had social media and those kind of platforms.
Right, okay.
Because now, I think we saw it with Caroline Flack and other people. When that's posted, that affects thousands and thousands of people. So that ability to, so often people will go onto Facebook or go on to whatever social media platform and talk about their loved one. That will affect people that have never met their loved one. So actually the impact of that, 37 people might be around the immediate person, and those 37 people are hugely impacted. But actually social media has made that have a ripple effect that is even wider than your 37.
So do you think then that, we talk quite often about how social media has an impact on young people? They're being exposed to things that really can affect their development. But do you think that social media has played a part in worsening suicide then?
I think it's a very nuanced debate that I think social media is here. It's here to stay. It's not going anywhere. We have to work within a changing kind of social environment. But I think it can be a force for good and it can be a force for bad. I think there is undoubtedly ways of finding people to back up your negative thoughts in a really unhelpful way. I think some of the social media environments are quite toxic sometimes around people not being positive and not constructing, and that because you can't see somebody, I think that compassion that people have naturally for each other is harder to find in a social media platform. But I also think it can be a force for real good. And I suppose one of the examples I would use would be we've introduced something called Cooth for young people. So across Lanarkshire, young people up to the age of 18, 26 for care experienced people, they don't turn people away. So they encourage young people generally to contact them, and it's cooth.com, free for Lanarkshire residents, where you can access social media platforms, where you can access one-to-one counselling online, and you can speak to other young people as well as a wealth of other self-help information. And when we talked about using Cooth, I was really worried about social media, because I worry about the dangers of social media and about people meeting other people in a dark place and then meeting other people, and that being a forum to reinforce each other's pain rather than being a force for good. But I've had to eat my words because Cooth is fantastic. Cooth, young people we get such good feedback from the young people who use it, but the platforms are moderated, so somebody always has oversight of the culture of those platforms and can intervene if it's going down a dark route. But the Cooth team will also, for a national organisation, they will link weekly with our clinical teams. So anybody that they are particularly concerned around, they'll actually raise that with the local teams, and they'll raise if there are themes and we're always aware around when you have one suicide, very, very quickly that can affect multiple young people, and very quickly you can have what we call suicide contagion, where unfortunately you have a lot of young people who act on their thoughts. So we're conscious to put anything we can do to mitigate risk. So Cooth will feed back how things are going, if there's any concerns, what themes are coming up for people, so that we can locally take action and do everything we can to mitigate any risk to young people and provide a safe forum. So young people tend not to want to come into a room and look at you and talk to you about their pain and their angst and their distress. That tends to be not a young person thing. Some people do, but most prefer a more anonymous format. And that's what I think Cooth provides for our young people in a safe way. So that's a version of social media that's been incredibly positive. So I think it's either way, and it's how we can tip the balance to a positive use of social media and maybe involve young people in those discussions and empower young people around doing it the right way and creating cultures of positive social media use and safety.
Yeah, just before we started recording, we were kind of, ranting a little bit.
We were blathering a bit.
There was a particular social media site that we were talking about where, I guess it's not really fair to pinpoint one. They've all kind of had challenges, I suppose, but it's nice to know that there's something like Cooth where it is moderated and that it will be, the safety's at the forefront of that app. So what was the website again? Did you say
is Cooth.com, www.cooth.com, and I think it asks for your postcode because it's something that is a service that we've commissioned, so it's free for anybody who lives, works, studies in Lanarkshire and is under the age of 18 or up to the age of 26 for care experienced people. I think though there's plenty for parents. I know lots of parents who've been on and looked at some of the information, so it's well worth a look really, no matter who you are.
And it's K-O-O-T-H.
K-O-O-T-H,
Yeah. Okay, brilliant. Okay. Excellent. So last time you were here, it was for our Shift the Focus series of podcasts, and while there was a bit of discussion about suicide in that, those podcasts were really about breaking down stigmas, but something we did talk about at the time was the statistics. Yes. And if you listen to that podcast, or if you've maybe listened to some of the podcasts in this series, you might already know that suicide statistics are posted for the public a year after the fact. So yes. In the last 2 or 3 months, I think it was August, maybe September, we had the numbers for 2023.
Yeah.
So did you, having had a bit of time to digest those statistics, what were your kind of reactions? Did you have any sort of notable observations to the statistics?
I'm always, as somebody who's passionate about mental health, passionate about supporting people to thrive, I do look at as soon as those statistics come out, I look to see what's happening. And statistics don't tell us the whole story, but they are important in terms of trends. And it pains me to say that we had more suicides in 2023 than we did in 2022. That has affected the 5-year rolling programme, the 5-year rolling average too. It's not huge numbers, but it is enough to give us some concern. perhaps not surprisingly, given the socio-political climate, the cost of living crisis, the challenges that people are facing. But we've seen across Scotland, I think it's a rise of 4% from 2022. That's mirrored in Lanarkshire. So across Lanarkshire, in 2023, we saw 111 deaths in 2023, up from 96 in 2022. So again, it's small numbers, and you're always really cautious around statistics, and when it's small numbers, 1 or 2 deaths can really affect your stats, but it's enough of a trend to have us all concerned that there is an upward creep around people who complete suicide, so that we really want to invest. So it's great to come along and do things like this, and I could talk for fortunately you'll not let me talk for hours, but I could talk for hours around suicide prevention. It irks me that in Scotland we have the highest suicide rate of all the home nations. That irks me because I love Scotland. Partly it's how suicide stats are collated, but I think there is something around Scottish culture that is not one of talking about things. That's why I like talking about stigma. I like talking about mental health, and I think we should all be talking about mental health. Some of the things that struck me around those 2023 statistics were we have that upward creep. That's painful for those that work in this, because every suicide is a tragedy, and we want to prevent as many of those as we possibly can. But the figures for men completing suicide are still resistant to coming down. So we know that men are still 3 times higher, more likely to complete suicide than women are. And we've talked about some of the reasons for that. We've talked about, historically, do men talk about how they feel? Do they access support? We know that women are more likely to seek support, but men are more likely to complete suicide. So women are more likely to attend their GP to talk about their mental health or to present to A&E, but men are 3 times more likely to complete suicide. The third thing that struck me about those statistics are the really intractable link with poverty. So those statistics, if you look at them, at the detail of them, you're 2.5 times more likely to complete suicide if you live in a poorer area of Lanarkshire than if you live in a more affluent area. Now, we know that poverty is linked to all kinds of inequalities with regard to health, but it's more marked for suicide than it is for any other health condition. So poverty is bad for your health generally, but it's particularly bad for your mental health. Which is why that kind of early upstream addressing inequality and creating the conditions for everybody to thrive is really the only way that we'll have an impact on those suicide figures.
Yeah, I mean, I read a book called Poverty Safari a couple of years ago. I don't know if you've read it, Darren McGarvey.
I haven't.
The Scottish rapper Loki. And, he talks about, because, he talks about his experience of growing up in poverty. And I guess what people maybe, if you're someone who, I don't know, just getting by, or maybe not just getting by, but then you get hit by, the cost of living, and you start to wonder if am I going to put food on the table for my kids, or if you're someone who can feed the kids, but there's no food left for you, and you kind of have to eat, which is horrifically in the UK in this day and age is the truth for some people. You're stressed, and when we're stressed, we don't maybe make decisions that are in our best interests. We've all done it probably in some way where you've had a hard week and you think, do you know what, let's just call in a pizza or something like that, and that's expensive. And you can kind of, I think when you start to think about wee things like that build up when you're in poverty, and you can suddenly see how it snowballs.
And it's absolutely right. One of the most powerful bits of work we've done over the last year is that we've delivered some mental health and suicide prevention training to our tackling poverty teams, and I think I learned as much from delivering that training as our colleagues did, just in terms of the complexity and the distress of people that are now struggling, and people that they're seeing more people than they've ever seen before who are financially struggling, and it's real struggles. It's not being able to feed themselves, feed their kids, heat their house, and whereas previously those teams could generally find a bit of money for people to make life a bit easier, I think that's getting increasingly difficult. So those teams are now faced with very, very distressed, often suicidal people who can't afford to heat their house, can't afford to eat, and they can't find any more money. What do those teams do? It's a really overwhelming position to be in, that's where those people are more likely to pick up distress than maybe some of our GPs, psychiatrists, psychologists are, because that's the pressing issue is no money. So we did a lot of work with those teams around actually sometimes just acknowledging that and validating that and responding compassionately to that. It's not going to sort all somebody's problems out, but that is the first step, is being able to just validate that sounds absolutely terrible.
Yeah.
And making time to listen to that is often enough for people to, doesn't sort it out, but people can maybe begin to see the wood for the trees and start to unpick that a little bit. So rather than immediately signposting somebody else, because actually sending somebody who can't afford to eat their house to a mental health professional, I've become increasingly political around my thoughts around that actually mental health support isn't what that person needs. What they need is money to live on, so that they've not got these daily struggles. So that's something that we work very closely, doing everything that we can to tackle poverty, because unless it's that whole Maslow's hierarchy thing, that unless people are able to eat, able to live, have a roof over their head, have those basic needs, actually you can't get to dealing with mental health. It's at that very basic level that people need support.
Yeah, I mean, something that I've been really keen to try and get across in these podcasts is that suicide prevention isn't, just about. It's not just about treating someone's depression. It's about having what you need to be able to survive, to live a good life. Yeah. It's about having access to money and support, and that's not what everyone understands, I guess.
I think and I think with COVID as well, people did start talking about mental health, and that's great, reducing stigma. We should all be talking about mental health, but were we talking about it in the right way? Are we talking about it in the right way? And I've had loads of conversations with the young people around if we didn't have mental health, life would be pretty miserable, because you would be a robot and you wouldn't have the ups and downs and the colour that life has. So we have everybody experiences joy, low points, anxiety, low mood, tiredness, and everything that comes along with that. That's life, and life throws things at you all the time. And again, that's life. So there is a little bit about the labels that we use around mental health tend to be quite medicalised ones. So we tend to talk about depression and suicide and clinical depression, eating disorders, bipolar disorder. We tend to think about them in clinical terms and don't think about, actually, this is about human beings. It's about human beings talking to other human beings and the power that can have. And actually the biological impact that can have, that we know that if we're kind and compassionate and feel connected, that has all kinds of health benefits as well. But we don't tend to have a language for that. And then when we start unpicking some of the more vulnerable groups, so looking at some of the ethnic minority groups, again, we don't have the language to even get anything like as far as that. So there's a whole lot of work that we need to do around diversity, around communities, around high-risk groups, that gets in and about not just not just diagnosing people who meet a clinical threshold, but actually about how do we support everybody in those communities.
What sort of factors might make a person more likely to complete suicide?
Oh gosh, you can look at the statistics, and the statistics will tell you that there are groups at higher risk. But the reality is that absolutely anybody is at risk of suicide. It can be ourselves, it can be our neighbours, our colleagues, our friends, anyone, irrespective of status or job or influence or affluence. Life can come along and chuck bad stuff at any of us. I suppose that said, there are sort of internal, external, environmental, socio-political factors that play into someone's resilience and conversely their risk of suicide. So we've talked about poverty and we've talked about gender and men being 3 times more likely. Both of those play key roles. But we also know that there are groups that are particularly vulnerable. We see poorer mental health in maybe people who struggle with addiction, people in the community justice service, whether it's homelessness, veterans, our LGBT communities, refugees, asylum seekers, and people that have suffered trauma or adverse experiences as children and care experienced young people. Really those groups of people who maybe don't have the opportunity to take up things that would preserve their own mental health. So good mental health is not equally afforded to all of us, and multiple factors will play into that. That doesn't mean that somebody that you don't expect can't be at risk of suicide. So I suppose for all of us, it's about just asking how people are. And if somebody looks like they've got the weight of the world on their shoulders, asking them how you're doing. Because that's 90% of our brains are tuned into non-verbal communication. You know when somebody walks into the room, especially if you know them well, you know they're not in a good place. And it's then it's on us to be asking about that.
Yeah, everyone can play a part in asking, how are you doing? But maybe even, are you thinking of
Absolutely.
suicide?
Are you thinking about suicide? And even going back, I trained, it's been 25 years ago. I think we were taught to do it in a very wibbly wobbly way. So you thought about a time where it's not been worth living and blah, blah, blah. Now I think we are encouraging people to use the word suicide because it is unambiguous. Have you thought life's not worth living? That's quite different to you thinking about suicide. And using that word, often if it's you that uses it, it takes away the stigma for the other person to reciprocate. Sometimes people, you can see a relief that that question's been asked, and there's almost actually, yes, I am. Sometimes just using the word makes people reflect on it as well and go, actually, do you know what, I am? And there's almost actually, now you've called that out, I am. So the word itself is really important, and we kind of need to get over that stigma of saying it, of using it about suicide. It's unambiguous, and it's really important if we're going to impact on those Scottish and Lanarkshire figures that we do talk about it and we do ask each other those direct questions.
And that we all do it. Everyone.
Yeah, everyone
absolutely.
does it. Because actually, it can be somebody standing at a bus stop. It can be somebody in a garden centre. It can be somebody, one of our colleagues, it was walking their dog in Strathclyde Park and did a suicide intervention with somebody who was about to take their life in So it can be when you least expect it, with who you least expect it. But that's on all of us to create that kind of environment and culture where we do care about each other and we do express that compassion and concern.
Yeah, it's so important. So this project and the series of podcasts as well is called Creating Hope in Our Community. What is there to be hopeful for?
Oh, I love hope. When I saw what your project was called, my heart did a dance, because I think hope is my favourite word. I think it's the most powerful word in the dictionary, and I'll tell you why that is. Because I remember years ago, in as a young junior research psychologist, we did some research into the role of hope and how it impacts upon us. So if you could buy hope, if it was a drug you could buy in the chemist, we would be saving lives left, right and centre. It's the most powerful drug that a chemist could sell. It keeps us healthy. It wards off illnesses. It keeps us healthier for longer. And you can even measure it. When I was working as a research psychologist, we would do interventions with people that the whole aim of that was getting people feeling a bit more hopeful and in control of what was going on. So specifically, we worked in the field of oncology. When you get a diagnosis, often you feel like all control's taken away from you. But if you can instill a little bit of hope, and it doesn't have to be, and just having those compassionate conversations that we were talking about is often enough just for people to come away feeling slightly more hopeful than they did. And I could tell you, you can measure it. You can take blood off. You can look at immune function, and hope is related to natural killer cell activity, T4 cell activity, LAC cell activity, all the good stuff. So all the good stuff that would be good in helping you fight off illness are impacted by that conversation, which is just incredible to me, that just by having a conversation and being compassionate and listening to someone can affect their body in a direction not only that helps them feel mentally better, but actually has a physical impact. And I remember doing the stats around those figures and just being absolutely blown away that your mind and your body is so interconnected, and hope is the thing. Hope is the thing that connects you. So feeling hopeless is really bad for our mental health, and feeling out of control, which I think links to some of those vulnerability factors that we were talking about in terms of, addictions and community justice and homelessness. And often that's a pervasive hopelessness that's really bad in every aspect, on every bit of your body. So if you do nothing else, go out and have compassionate conversations with people, because, just that in itself is saving us lives and helping us live better.
That's lovely. And it's so simple as well.
Yeah,
when you put
absolutely.
It like that.
It doesn't cost anything.
Yeah.
It doesn't cost anything to compassionately have conversations with people.
No, absolutely not. Okay, we're coming up to the home stretch then, Jenny. Where can people go to for support then?
Okay, so we've talked about Cooth and young people, and I think Cooth is a fantastic service. If you are struggling, please reach out to somebody. There's always somebody to talk to. And I'm going to be possibly the one of your people in your podcast who's going to stand up for GPs. I don't know if anybody has stood up for GPs yet, but I will stand up for GPs, because yes, they're busy, but actually all the GPs I know and work with do want to support their patients, and they can discuss whether medication, specialist services, just someone to talk to in the practice. We've got link workers now. We've got mental health nurses who provide a kind of supportive role. So GP is always an option. The other service I really like is, I think, 111. That one, if somebody's really struggling, NHS Inform, call 111, particularly when the practice is closed. It's an easily accessed service where there's a team of trained professionals who link with our own, talked about the psychiatric liaison team. So 111 will directly link with psychiatric liaison team and get you the support that you need. So it might be just a bit of advice and signposting someone to talk to, but it might be more than that. And that's, you can get that access to that urgent crisis support if you need it. Samaritans 24/7. Always at the end of a phone. Calls are free and confidential. That number is 116 123. Breathing space as well. That's open during the week, 6 p.m. to 2 a.m. Friday and Monday, 6 p.m. to 6 a.m. 0800 83 8587. And that's somebody to talk to, that connection, somebody compassionate, somebody experienced, trained to listen to any of your kind of support, emotional distress kind of needs. Always crisis lines are available. Shout is a free confidential text messaging service for people that maybe don't have the words, don't want to use the words, want the anonymity of a text. There's a text service, text 85258. And finally, just a wee kind of shout out for South Lanarkshire's info line, 0330 3000 133. And they can tell you about some of those early intervention type resources, including Healthy and Happy and lots of the fantastic voluntary sector organisations. It's a kind of one-stop shop where they can tell you about a whole load of stuff that's happening, whether that's leisure, whether it's social, whether it's just connecting into your community. They've got a range of information, so always worth a call.
Lovely. Well, that's very comprehensive. Jenny, thank you so much for your time. Thanks for coming along again.
But great to meet you. Thanks for having me.